We back again with our last presentation of second day of today with Dr. Bekir Sıtkı Aslan from capital city of Turkey, Ankara. Dr. Bekir Sıtkı gonna present and share his knowledge with us in Femto laser assisted cataract surgery with digital navigation. Dr. Bekir, floor is yours. Please share your experience.
Mr. Çakmak, thank you very much inviting me to this very impressive and wonderful meeting.
We are honored with your presentation as well.
Well, I take this as a privilege, and I will take this privilege as an honor. Thank you very much. Thank you. Now, I'm going to share with you what we are doing at the moment in Ankara about our cataract cases. The cataract cases, apparently, all over the world, people are doing a lot of cataract surgeries. Millions of cataract surgeries are carried out. But the expectations of the patients and the present technological achievements just changed our understanding of how we are going to operate. So let me share my screen with you and then proceed accordingly. Lovely. Excuse me, just a moment, please. Stop video participants. Excellent. More sound optimize. Excellent. Okay. Well, this is our hospital view, and my email is below. The name of the hospital is Ankara Memorial Hospital. And I'm going to speak about my experience with femto laser assisted cataract surgery with digital navigation. Oh, I'm sorry. Okay, let's move ahead. Okay, can we reach refractive goals in cataract surgery? This is a basic question I'm going to discuss with you through the whole presentation. There are two answers. If yes, then how are we going to achieve a refractive goal that will make patients very happy? And if no, then why we cannot do this to our patients? This is crucial. We cannot reach the goal in refractive cataract surgery in general due to residual refractive errors, inflammation, and ocular surface problems. We know that these issues should be solved so that we can have a very good, reliable result that will make both the surgeon and the patient very happy. World Health Organization's website gives us a clue about what's going on all around the world. And the refractive solutions are offered to less than 15% of cataract surgery patients, according to World Health Organization. Less than 3% of all cataract surgeries are performed as femto cataract. All over the world, only 13% of cataract cases can get treatment they need. So, it seems as though we are far from perfect. In the EURECO, which is an organization carried out by European Society, EURECO registration system gives us an idea about 1 million cases operated by the European surgeons. 70% of eyes showed one diopter deviation. Refractive deviation is higher, especially in short eyes. Among 17% of cases in 70,000, almost 7,500 patients with corneal astigmatism, metropia was targeted in 78% of the eyes. However, it could not be achieved in 52% of the cases. In 43% of cases, one diopter or less astigmatism was detected. So, in summary, we are really very far from perfect. So, what we need? Advanced precision surgery with manual applications nowadays is not feasible. You have to do biometry, transcription, planning, marking, cyclotorsion, surgically induced astigmatism. You have to consider surgically induced astigmatism. You have to do a very well-centered and good overlapping capsulorhexis, and you have to position the IOL, and you have to optimize the outcome. These are the points when you perform a manual surgery. These are the points, potential points of failure in this process. So there are so many unknowns. Those should be carried out, and you must be very precise. So we have to mention briefly what the limitations in classical cataract surgery are. Security is 10 times less than the LASIK surgery. Predictability of the results are half of the less predictability. Distance visual acuity is half of the predictability of LASIK surgery. Astigmatism correction is limited. Presbyopia correction is limited. Effective IOL detection is almost impossible when you are doing a classical cataract surgery. So there are a few points that I have to mention about why there are limitations. First of all, when you're performing corneal incision, the classical surgery is not optimized, and it has an impact on the induced cylinder. And the safety is another crucial point that I have to mention. Capsulorhexis with the current surgery is variable sized, not centered well. This has an impact of variable IOL position and effective lens power. Lens fragmentation is the third part, which has an effect on the final outcome, and excessive ultrasound power, delayed visual recovery, and loss of endothelial cells and capsule rupture should be the keywords to be mentioned. Refractive cataract surgery has certain steps. You have to prepare the patient with biometry, ocular surface evaluation, inflammation control, and you have to check for the systemic problems of the patient, namely prostate, diabetes, hypertension, and many others. Intraocular lens selection are variable, and you can choose between single to three-piece lenses, to monovision to multifocality. Surgical technique depends on extracapsular surgery, and depending on the patient's eye, and mainly extracapsular cataract phaco, Femto phaco, or Femto phaco plus variant sport of Femto phaco may be the choice. Post-op treatment and follow-up of these cases should be very precisely carried out. Surgical preparation, ocular biometry, and of course the back of the eye, fundus preparation are the crucial parts of the surgery. We nearly always perform a corneal tomography. We nearly always perform an OCT of the macula, and sometimes we perform the OCT of the disc. And we take our biometric measurements with the LensStar with the newest software. In the past, we knew that posterior corneal astigmatism has an effect on the final outcome. Unfortunately, with the Scheimpflug technology, posterior radius of the curvature cannot be measured accurately in all conditions. This is a deprivation of the outcome. So we are using Barrett torque calculator to get hold of the best option to treat astigmatism and, of course, best power to put into the eye. When you are going to put this lens in the eye, you need some surgical tools to find out whether you are putting this lens correctly into position. And you need a kind of surgical guide, and this surgical guide in our case is Varian image guided system. It not only helps us to put the lens just on the visual axis, but it also helps us to put the lens, if it's a toric one, on the correct visual axis. Well, I'm very proud to share this picture with you. The first intraocular lens for the treatment of cataract was implanted by Sir Harold Ridley at St. Thomas Hospital on the 8th of February 1950. And this picture is in Denmark in 1987, and Harold Ridley is accompanied by myself. And I always take this picture as an honor of knowing Mr. Harold Ridley. So, Mr. Harold Ridley introduced us the first IOL, and since then we have a bunch of intraocular lenses, starting with the foldable ones, adding filters, adding toric correction, and adding also multifocality. And nowadays, of course, accommodation is another fruitful approach that we can see in the very near future what we are going to get. There are certain lenses that are in the market that may help us to see both near, intermediate distance, and distance. There are lots of them, and we just choose the best one, the best option, depending on the diagnostic outcome of the specific patient. We do not implant one lens to everybody, but we choose the correct lens so that it will fit to that person's eye, so that the patient can get a very good visual outcome. It may be, intraocular lens selection may be, as I said, one piece. You can have a monovision outcome, or you can use a multifocal lens, as you see here. Recent meta-analysis of peer-reviewed publications revealed evidence of high levels of patient satisfaction in general. The spectacle independence was 80% or more, 90% for distance vision, 100% for intermediate vision, and 70% for near vision. This is an outstanding outcome with the present lenses if they are chosen correctly for the specific patient. Of course, this picture shows us what kind of a vision at the end of the day the patient will get. And we just describe this patient, and also we get feedback from the patient how the patient may benefit from the implantation of this lens. Nowadays, we are using a new technology called Visual Behavior Monitor. This Visual Monitor fully documents the way one uses the real-world visual system. We put this system on the patient with the eyeglasses on the patient's eye and try to find out how the patient is using his or her eye during the day. And in this slide, the focus curve graph left here in the left shows that this patient performs most of his visual tasks by imaging distance between 0.4 to 1 meters. So this is also in the right. We see that this patient also has 61% of the patient's vision occurs in good lighting conditions, and 70% in mesopic conditions, and 22% under scotopic conditions. In this patient, if a monofocal IOL is implanted targeting emetropia, then he will not use glasses for 8% of the day and will require glasses for the medium and close tasks for 90% of the day. So at the end of the day, even if you do a perfect surgery with a monofocal IOL and with an emetropia target, still this patient will not benefit from the surgery as it is expected. Well, I will now switch again to Varian image-guided system that really eliminates the potential error in surgical steps. We take the patient's image with accurate biometry and auto data uploading. We plan the surgery, and after the planning, we have another unit in the operating theater that will guide us to make cataract construction, IOL positioning, surgical optimization. So this result-oriented surgery comes out with outstanding outcomes. Varian Surgical Planner this is the picture you get first. You make your decision where you're going to put your incisions, where you are going to, if you're going to correct astigmatism by corneal incisions, and of course, it also evaluates the corneal astigmatism, which is a very good benefit. And this is the digital marker in the operating theater. This operating theater, with the digital marker, you get the patient on the bed and you adjust where you are going to sit, and then you just make your locations of the incisions, and apparently you have this size of the capsular axis that's shown here, and you decide your way of centration, whether it will be on visual axis or with limbus, whatever it is, it's up to your decision. So, and then this is the picture on the patient's eye. We have this kind of appearance, and this shows where the incisions are. These are the landmarks where you are going to have this surgery. So, and at the end of the surgery, Verion shows us exactly where we are going to put this lens with regard to centration, plus the axis of the lens is going to be planted. Well, what is new then? Is it really worked? Verion digital surgery guide femtosecond laser technology reduces error rates and allows surgery in sharp margins. This improves clinical outcomes, which is very, very important. And apparently, you can get extremely sensitive corneal incisions, capsular axis, nuclear fragmentation, intraocular lens placement. But of course, this technology has some drawbacks: financial problems, long learning curve, and complications that could threaten the vision. This is a system we are using. This is a LensX system. We get a picture here, and we evaluate the patient's eye, and then we execute. Another point that you have to mention is active fluidics. Active fluidics is something that we are using with the Centurion phaco device. The question was, can we keep the anterior chamber stable? Can it help control inflammation? Yes, if you don't keep the anterior chamber stable, you cannot have a full control on the final inflammation control. So, fluid control, active fluidics system just match to each other so that you can have a very stable anterior chamber, and the final outcome of the surgery becomes brilliant. Nowadays, we are using another tool called active sentry, where the anterior chamber maintenance is controlled via sensors at the handpiece. As the incision becomes smaller, fluid flow into the eye is limited even if phaco-parameters are modified. This reduces the surgical efficiency. So, in a gravity system, in many of these surgical systems, phaco systems, the higher the bottle raised, the higher the intraocular pressure will become. And the risk of performing phaco at higher intraocular pressure, you will definitely get endothelial cell damage, optic nerve damage, deterioration of retinal choroidal perfusion, and you are operating, if you put your bottle at a height of 100 centimeters, you are operating under a pressure of 74 millimeters of mercury, which is unbelievably high. So, with a femtosecond nuclear fragmentation, you can effectively disassemble the nucleus, protect the posterior capsule, and apparently you can control the phaco time and corneal endothelium. Femtosecond nuclear fragmentation safety is simply because you are decreasing the phaco energy, reducing the phaco time, less endothelial cell damage, and may reduce potential for inflammation and corneal burns. This is how we are executing this surgery. We are, with the Verion planner, we make our decision how we are going to make this surgery. Now we are putting our incision Now it's the capsule real-time OCT. We just find out whether our target is okay. Now this is the real-time OCT of the lens, and we adjust where we are going to fragment. And in this case, we plan to make limbal relaxing incisions. And we adjust also that one. And here we are now adjusting the incision. Now we put the incision at the desired place. And also the limbal relaxing incision is localized properly. When we set everything properly, then okay, we set it everywhere, bits and pieces. It's now over. Now, let's see what's happening when we adjust. The capsulexis is made. Now the fragmentation is carried out. And astigmatic incisions are made. And finally, the incision we are going to enter the eye is prepared. Now the treatment is complete. And these are the parameters we are using to remove the fragmented material. And this is this case. I will share with you how we are putting a lens that has both toric capacity and multifocality. We remove all the viscoelastic from the anterior surface of the lens and posterior surface of the lens. And we remove all the viscoelastic, and then we put the lens as you see, there are marks on the lens. We put this on in accordance with the line Varian is showing us. We call this digital navigation system. So, if you are performing a manual surgery, we call this test a point spread function test. And we also make a point spread function test, and MTF values of this test, the graphics of the MTF values are clearly seen. And with a manual test, the patient sees like this. And with the laser, with the same lens, the patient has a visual acuity like this, which is more controlled, more precise. And modulation transfer function test also graphic shows us a very smooth graphics that shows us that the patient has a very good outcome. Treatment is also crucial, and you have to use good antibiotics, non-steroid anti-inflammatories, and steroids to achieve good refractive result for 3 weeks. Refractive cataract surgery, there has always been discussions whether to switch to ICCE to ICCE, ICCE to phaco, and many other technologies always have some kind of resistance. Now, phaco to Varian-guided femtophaco is the choice. To improve is to change. To be perfect is to change often, says Winston Churchill. So finally, I would like to summarize what I am telling you. One, careful and individualized selection based on pre-existing conditions, visual needs, realistic expectations. This is our dogma. We follow these rules nearly in all cases. On the knowledge of different optical designs, visual performances of multiple IOLs, proper surgical technique, and eventual complicated management is our criteria to follow to do a very good surgery so that the patient expectations are reached. I would like to thank you very much, and I would like to send my greetings from Ankara. My email is as follow, bsa@outlook.com. Any questions are welcomed. Thank you very much.
Dr. Bekir, thank you for very detailed, comprehensive presentation for eye treatment, especially. I received a message from your student from Ukraine, Dr. Christina.
Oh, hello, Christina.
Saying hello to you and asking one question, saying that do you prefer to do corneal incision or implementation of toric lens for astigmatic cases?
Well, for astigmatic cases, this is a very, very important and nice question. And astigmatic cases, up to 1.25 diopters, that is with the rule, I correct it with limbal relaxing incisions. But, excuse me, when the patient has 0.75 diopters of against real astigmatism, I would start with the toric IOLs. And about 1.25 with the rule and about 0.75 against real astigmatisms, the surgical tool should be toric IOLs.
Thank you very much for the answer. I hope that we can host you once again in our coming virtual conference. It was very beneficial for our listener because there were a lot of eye surgeons was listening and following you from different CIS country, especially from Ukraine. There were more than 45 doctors was interested to listen your presentation. Thank you very much joining.
I'm delighted to be here. I'm delighted. Thank you very much for the invitation. Thank you.
Very much.